going to start the Kanski lecture series, and this is the part 2 of the conjunctiva. And today we are going to discuss about the bacterial conjunctivitis. Acute bacterial conjunctivitis. It's one of the most common of the diseases that you will encounter in the OPDs is the acute bacterial conjunctivitis. Acute bacterial conjunctivitis is a common and usually self-limiting condition caused by the direct contact with infected secretions. The most common isolates are Streptococcus pneumoniae, Staphylococcus aureus, Haemophilus influenza, and Moraxella catarrhalis. A minority of the severe cases are caused by a sexually transmitted organisms, Neisseria gonorrhea, which can readily invade the intact corneal epithelium. Meningococcal Neisseria meningitis conjunctivitis is rare and usually affects the children. So, what is it trying to say is basically any secretion, if infected secretion, when it comes in contact with the eye, it can cause the infection. And the most common is the Streptococcus pneumoniae, Staph aureus, Haemophilus influenza, and Moraxella. And there are certain conditions that can readily invade the intact epithelium like Neisseria gonorrhea. Diagnosis, symptoms: acute onset of redness, grittiness, burning, and discharge. So very important, whenever a patient comes, he can complain of the redness of the eyes, itchiness, burning, and the most common it will be the discharge will be the mucopurulent to purulent discharge. Involvement is usually bilateral, although one eye may be infected 1 to 2 days before the other. On waking, the eyelids are frequently stuck together and may be difficult to open. Systemic symptoms may occur in patients with severe conjunctivitis associated with gonococcus, meningococcus, chlamydia, and H. influenza. So these are the organisms which can also cause the systemic association, but it is usually important in the children where it causes the systemic association. In children, the possibility of the progression to systemic involvement should always be borne in mind. Signs are variable and depend on the severity of the infection. The vision is normal because the cornea is usually, if not involved, the vision will be normal. Eyelid edema and erythema may occur in severe infection, particularly gonococcal. Gonococcal is severe infection. Whenever such cases occur, it can cause eyelid edema and erythema. Conjunctival injection, as previously described in C, the discharge can initially be watery, mimicking viral conjunctivitis, but rapidly becomes mucopurulent. So, mucopurulent is basically the discharge of concern in case of bacterial meningitis, bacterial conjunctivitis. Hyperacute purulent discharge may signify gonococcal or meningococcal conjunctivitis. Superficial corneal punctate epithelial erosions are common. Peripheral corneal ulcerations may occur in gonococcal and meningococcal infection and may rapidly progress to perforation. So these are meningococcal and gonococcal are the infections which are usually can intact the intact corneal epithelium and causes the corneal diseases. So these are the pictures that are seen. Bacterial conjunctivitis: A is showing the eyelid edema and erythema in severe infection. B is showing the diffuse tarsal and forniceal conjunctival hyperemia. So you can see the redness of the eyes. And C is showing the mucopurulent discharge, and D is showing the profuse purulent discharge secondary to gonococcus. Lymphadenopathy is usually absent except in severe gonococcal and meningococcal infection. So lymphadenopathy is present in the case of the severe gonococcal and meningococcal infection. So investigations are not necessary, but you can do it if you want to rule out the certain kind of organism. Investigations are not performed routinely but may be indicated in the following situation. In severe cases, binocular conjunctival swabs and scraping should be taken for urgent gram staining to exclude gonococcal and meningococcal infection. Gram negative kidney shaped intracellular diplococci. So basically, if you want to take a sample, then you take the swab and send it for the staining. And if the usually the meningococcal and the gonococcal are gram negative and they are a diplococci like this. Culture should include enriched media such as chocolate agar or thiamartin for Neisseria gonorrhea. Polymerase chain reaction may be required for less severe cases that fail to respond to treatment, particularly to rule out the possibility of the chlamydial and the viral infection. Tip: a hyperacute prurient ocular discharge may be a sign of gonococcal or meningococcal conjunctivitis. A specimen should be taken for microscopic culture and sensitivity in order to prescribe an appropriate systemic antibiotics treatment. So, what will be the treatment that will be done in case of bacterial conjunctivitis? Of course, you will have to give the topical antibiotics is the mainstay of the treatment. About 60% resolve within 5 days without treatment. If the treatment is not given, still 60% will resolve. Topical antibiotics usually 4 times daily up to a week for up to a week, but sometimes more intensively are frequently administered to speed recovery and patient prevent reinfection and transmission. There is no evidence that any particular antibiotic is more effective. Ointments and gel provide a higher concentration for longer periods than drop, but should be avoided during the day because the blurred vision may follow. The following antibiotics are available. So you can give the ointment as well, but the ointment causes the blurring of the vision. So you give it basically at night for the longer duration of the action. So there are certain topical antibiotics. Some are causing resistance, some are newly made, and some are for the severe infections. Chloramphenicol, aminoglycosides, gentamicin, neomycin, tobramycin, quinolone, ciprofloxacin, ofloxacin, levofloxacin, lomifloxacin, gatifloxacin, moxifloxacin, becifloxacin, macrolides, erythromycin and azithromycin, polymyxin B, physitic acid, and bacitrin. So basically, these are all the antibiotics that you can use for the case of the bacterial conjunctivitis, depending on the severity of the infection and depending on the um, mm, type of organism you are suspecting. Some practitioners, particularly in the USA, believe that chloramphenicol should not be used for routine treatment because of the possible link with the aplastic anemia. So, it is a systemic complication of chloramphenicol is a aplastic anemia. Gonococcal and meningococcal conjunctivitis should be treated with a quinolone, gentamicin, chloramphenicol, or bacitracin 1 to 2 orally, as well as systemic therapy. See below. So, gonococcal infection should also be given the systemic antibiotics as well. Systemic antibiotics are avoided in the following circumstances. Gonococcal infections are usually treated with the third generation cephalosporins such as ceftriaxone. Quinolones and some macrolides are alternative. It is essential to seek from the microbiologist or genitourinary specialist. So basically, it is a sexually transmitted organism. So you have to give the systemic antibiotics as well, and for that we use the ceftriaxone as the mainstay of treatment. H. influenza, particularly in children, is treated with oral amoxicillin and with clavulanic acid. There is a 25% risk of developing otitis and other systemic problems. So you can give H. influenza with augmentin, basically. Meningococcal conjunctivitis, particularly in children in whom early systemic prophylaxis may be life saving, as up to 30% may develop systemic disease without treatment. The advice of pediatric and infectious disease specialists must be sought, but if in doubt, treatment with intramuscular benzyl, penicillin, ceftriaxone, or cefotaxime or oral ciprofloxacin should not be delayed. And we use systemic antibiotics in case of receptal or orbital cellulitis. So basically, in case of meningococcal infection, we give intramuscular benzyl penicillin. Topical steroid may reduce scarring in membranous and pseudomembranous conjunctivitis. Irrigation to remove. So, but the steroids are usually used after sometimes with the antibiotic or when the antibiotic is effective. Irrigation to remove excessive discharge may be useful in hyperpurulent cases. Contact lens wear should be discontinued until at least 48 hours after the resolution of symptoms. Contact lens should not be worn while topical antibiotic treatment continues. Risk of transmission should be reduced by hand washing and the avoidance of towel sharing. Review is unnecessary for most mild to moderate adult cases, although patients should be cautioned to seek further advices in the event of deterioration. Statutory notification of the public health authorities may be required locally for some causes. So, these are the journal measures that you can take with the case of acute bacterial conjunctivitis. Giant fornix syndrome. So, as the name suggests, the fornix is giant. Giant fornix syndrome is an uncommon entity causing the chronic relapsing pseudomembrane purulent conjunctivitis. So, what is this word is very important. The joint fornix syndrome, it is a chronic disease. It relapse again and again. It's a recurrent disease. Pseudomembrane, it forms the pseudomembrane. It's it is a purulent disease, and discharge is purulent in this case, and the conjunctivitis is present. So what is this? Chronic relapsing pseudomembrane purulent conjunctivitis. Five things to remember in a giant fornix syndrome. It is believed to be a retained debris in the voluminous upper fornix, acting as a focus for persistent bacterial colonization, usually Staph aureus, in an elderly patient with a levator disinsertion. So, how it happens is because the fornix become large. How it become large? Because of the levator disinsertion due to age-related changes. There is an accumulation of the organisms in it, especially the Staph aureus, and it causes the giant fornix syndrome. Large protein aggregation may be visualized in the upper fornix, though double eversion with the retractor may be necessary to identify this. Basically, protein aggregates are seen, but because of the large fornix, you have to elevate the lid two times to see these types of aggregates. Secondary corneal vascularization and lacrimal obstructions are common. It is frequently unilateral. Um Treatment involves repeated sweeping of the fornix with a cotton tip applicator and a topical and systemic antibiotics. Intensive topical steroid may helpful. Surgical reconstruction of the fornix may be necessary in a recalcitrant cases. Sometimes you need to do the surgery if the disease is recurrent again and again, but mostly it is treated with the topical antibiotics. Adult chlamydial conjunctivitis, so very important. So there is uh, conjunctivitis, that is chlamydia trachomatis. It can cause so chlamydia can cause two types of variant, trachoma and trachoma, which is common in children, and another adult inclusion conjunctivitis. That is basically more related to the type of serological variants in this chlamydial trachomatis. So, pathogenesis chlamydial trachomatis is a species of chlamydia, a phylum of bacteria that cannot replicate extracellularly and hence depends on the host cell. So, you need host cells to replicate, so it cannot replicate extracellularly. They exist in two principal forms: a robust, effective extracellular and elementary bodies, and a fragile intracellular replicating reticular body. So, in intracellular, it's replicating and it is called the reticular body, and extracellularly, it is a more robust form, which is called the elementary body. Adult chlamydial inclusion conjunctivitis is an oculogenital infection usually caused by the serological variant D to K of chlamydia trachomatis and affect 5 to 20% of the sexually active young adults in Western countries. The transmission is by the auto inoculation from the genital secretion, although eye to eye spread probably account for 10%. The incubation period is approximately a week. So, basically, the chlamydia species have the serological variant from A to K. The A to C causes the trachoma, whereas D to K causes the adult inclusion conjunctivitis, and the mode of transmission is a sexually transmitted route. Urogenital infection in males. Chlamydial infection is the most common cause of the non-gonococcal urethritis, also termed as the non-specific urethritis. It should be noted that the latter term is sometimes used to mean urethritis in both gonococcal and chlamydial infection and have been ruled out. Chlamydial urethritis is frequently asymptomatic in man. Chlamydial trachomatis may also call it epididymitis and can act as a trigger for the Ritter syndrome. So basically in males, what does it cause? It causes the most common is the non-gonococcal. If the gonococcal is not a cause of urethritis, most commonly it is the chlamydia. And the chlamydia cause is asymptomatic, but it can also cause epididymitis and it can also act as a trigger for Ritter syndrome. In female, the chlamydial urethritis typically causes dysuria and discharge. It may progress to pelvic inflammatory disease, carrying a risk of infertility. Approximately 5 to 10% of the women with PID develop perihepatitis, which is known as Fitz-Hugh-Curtis syndrome. So basically, in a case of female, what it causes dysuria, and dysuria can causes the infection in the inflammatory reproductive tract, which is known as pelvic inflammatory disease, and it can cause infertility. And when it also involves the liver, area of the liver, which is called perihepatitis, it is known as Fitz-Hugh-Curtis syndrome. Now let's see this classification. Chlamydial trachomatis has two types: trachoma inclusion conjunctivitis agents and the lymphogranuloma venereum agent. The lymphogranuloma venereum agent is caused by the L1, L2, L3 immunotypes. Trachoma inclusion conjunctivitis has a serological variant A, B, and C. A, B, B, A, and C serover causes trachoma, whereas D, E, F, G, H, I, J, K serover causes genital and other systemic and ocular diseases, which is known as adult inclusion conjunctivitis. Diagnosis consists of the subacute onset of a unilateral or bilateral redness, watering, and discharge. Untreated, the conjunctivitis become chronic and self-limiting, may persist for several months. It is important to inquire about the sexual exposure if chlamydial conjunctivitis is suspected. So what it causes? It is a bilateral disease. It causes redness, watering, and discharge is usually mucopurulent in this case. Untreated become chronic, but it is self-limiting. Signs are usually watery or mucopurulent discharge, tender periocular lymphadenopathy. So it is very important that in case of chlamydial conjunctivitis, it also causes the lymphadenopathy, periocular lymphadenopathy. And one more thing that is very common with the adenoviral, it causes the subepithelial infiltrate as well. Always remember that. Large follicles are the most prominent in the inferior fornix and may involve the upper tarsal conjunctiva. Superficial punctate keratitis is common. Perilimbal subepithelial corneal infiltrates may appear after 2 to 3 weeks. So, perilimbal, the area around the limbus, the cornea is becoming subepithelially infiltrate and it develops after 2 to 3 weeks. Chronic cases have a less prominent follicles and commonly develop papillae. Mostly bacterial and viral causes the follicular conjunctivitis, and chlamydia also causes this, but if the case becomes chronic, it causes the papillae formation. Mild conjunctival scarring and superficial superior corneal penis are not uncommon. Investigation: tarsal conjunctival scrapings are obtained using a spatula or the blunt tip of a scalpel blade. Nucleic acid amplification tests such as PCR are likely to be the investigation of choice in time, but validation for ocular specimen is limited at present. Giemsa staining for basophilic in intracytoplasmic bodies is performed by applying scraping onto the glass. So basically, PCR is the investigation of choice, mm, but sometimes it's not possible to do PCR. Then we go for the Giemsa staining, and what the Giemsa staining will show, it will show the basophilic intracytoplasmic. Inside the cytoplasmic there will be the bodies. Direct immunofluorescence detects free elementary bodies with approximately 90% sensitivity and specificity. So, what is the elementary bodies? As we told you, elementary bodies are those that are the extracellular robot form of the chlamydia, and the immunofluorescence will show these free elementary bodies, and it has a 90% sensitivity and specificity. Enzyme immunoassay for the direct antigen detection is also useful. McCoy cell culture is highly specific. So you have to remember it for the MCQ's point of view that McCoy cell culture is specific for the chlamydia. Swab taken for the bacterial culture and serology may be helpful in selected cases. Treatment empirical treatment may be given if the clinical picture is convincing. Pending investigation result, referral to a genitourinary specialist is mandatory in confirmed cases, particularly for the exclusion of the other sexually transmitted infection, contact tracing, and pregnancy testing. So you have to rule out the sexual infection as well. If the urethritis and some things are also involved. Systemic therapy involves one of the following, so you have to give the systemic therapy as well. And what is it? Azithromycin 1 gram repeated after 1 week is generally the treatment of choice, although a second or third course is required. In up to 30% of the cases, some guidelines advocate only a single 1 gram dose. So you can, what you can give, you can give a single dose of 1 gram azithromycin, but usually the course is 1 gram, and after 1 week we give 1 gram. Doxycycline 100 milligram twice daily for 10 days. Tetracyclines are relatively contraindicated in pregnancy, breastfeeding, and in children under 12 years of age. We know that the tetracyclines are usually avoided in breastfeeding, pregnant females, and in a children under 12 years of age. Then what will we give in this cases? We can give erythromycin in this case. Amoxicillin and ciprofloxacins are the alternative. Topical antibiotics such as erythromycin or tetracycline ointments are sometimes used to achieve rapid relief of ocular symptoms but are insufficient alone. Reduction of transmission risk involve abstinence from the sexual contact until completion of treatment 1 week after the azithromycin. So when will we start sexual intercourse? We can after the 1 week of the azithromycin together with other precaution or for infectious conjunctivitis. Retesting for persistent infection should take place 6 to 12 weeks after treatment. It is important to be aware that symptoms commonly takes weeks to settle and that follicles and corneal infiltrates can take months to resolve due to a prolonged hypersensitivity response to the chlamydial antigen. Tip: in a patient with adult chlamydial conjunctivitis, other sexually transmitted infection should be excluded. So you can see the figure 6.6 and it shows the adult chlamydial conjunctivitis. It is showing A is showing the large fornical follicles, and B is showing the superior tarsal follicles, and C is showing the peripheral corneal infiltrates, and D is showing the superior penis formation. Next is the trachoma. Trachoma is also caused by the chlamydia trachomatis, but it is common in children, and it is also very common in it is caused by the serological variants A to C. Pathogenesis: trachoma is the world leading cause of preventable irreversible blindness. So it can be the preventable blindness, but whenever the blindness occurs, it's usually the irreversible cause of blindness. It is related to poverty, overcrowding, and poor hygiene, the morbidity being the consequence of the establishment of the reinfection cycles within communities, whereas as an isolated episode of trachomatis conjunctivitis may be relatively innocuous. Recurrent infection elicit a chronic immune response consisting of the cell mediated delayed hypersensitivity type 4. So what type of hypersensitivity is associated with it? Type 4. Reaction toward the intermittent presence of the chlamydial antigen and can lead to loss of sight. Prior contact with the organism confers short-term partial immunity but also lead to a heightened inflammatory reaction upon the infection. So sometimes if the organism one is already infected with the chlamydia trachomatis, the second time it can offer a short term protectivity, but if the reinfection occur, it can lead to the increased inflammation. So that is why vaccinations are not that helpful. Vaccination has an effect similar to primary infection in sensitizing the individual, and as a consequence is not helpful. The family child care group is the most important reinfection reservoir, and the young children are particularly vulnerable. The fly is an important vector, but there may be a direct transmission from eye or nasal discharge. Trachoma is associated principally with the infection of the serovar. The A, B, BA, and C of chlamydia trachomatis, but the serovars D to K conventionally associated with adult inclusion conjunctivitis and other species of the chlamydia family, such as Chlamydophila psittaci and the Chlamydophila pneumonia, have also been implicated. So these basically it is caused by A to C variant, but such species can also cause the trachoma. Diagnosis features of trachoma are divided into active inflammatory stage and a cicatricial chronic stage with a considerable overlap. A World Health Organization grading system is in use. So this is the World Health grading of trachoma. Very important, you must remember it, which is the FIS2. FIS2 mean, you have to remember FIS2: follicle, inflammation, scarring, trichiasis, and opacification. So these are all complications of the trachoma. So the follicles are formed in the trachoma. Trachomatis inflammation, follicular formations. Five or more follicles greater than 0.5 mm on the superior tarsal plate. If the superior tarsal plate, so where does the follicles usually formed? It is formed in the fornix. But if the follicle is formed in the tarsal plate, then it is the sign of the superior tarsal plate. Then it is a sign of the trachoma. Trachomatis inflammation (TI) intense diffuse involvement of the tarsal conjunctiva, obscuring 50% or more of the normal deep vessel papillae are present. So in the second scene, there is there is not a visualization of the tarsal vasculatures. TS is a trachomatis conjunctival scarring, easily visible fibrous white tarsal band. TT is a trachomatis trichiasis, at least one lash touching the globe, corneal opacity sufficient to blur the details of at least part of the pupillary margin. So it is divided into active trauma and cicatricial trachoma. Active trachoma is the most common in preschool children and is characterized by the following. So, active trachoma common in preschool children. Mixed follicular and papillary conjunctivitis associated with the mucopurulent discharge. So, in the case of chlamydia, we have seen that it is mostly associated with follicle, but papillary can also form. And with a mucopurulent discharge in children under the age of 2 years, the papillary component may predominate. Very, very important for the MCQ's point of view that a papillary component is predominant in children. Superior epithelial keratitis and a penis formation. It is also a case of an active trachoma, that there is a superior epithelial keratitis and penis formation. Cicatricial trachoma is prevalent in middle age. Linear or stellate conjunctival scar in the mild cases, or broad confluent scar outline in the severe diseases. So conjunctiva is usually scarred. Although the entire conjunctiva is involved, the effects are most prominent in the upper tarsal plate. Basically, it is a disease of the upper lid. So you have to see the signs of trachoma mostly on the case of the upper lid. Superior limbal follicles may resolve to leave a row of shallow depressions, Herbert pit. So, whenever the limbal formation is limbal follicles are present, when they resolved, they give the shallow depression and it is a blackish in color, the Herbert's pit. Trichiasis, dystrichiasis, and corneal vascularization and cicatricial entropion can occur. Severe corneal opacification, dry eye caused by the destruction of the goblet cells and the ductules of the lacrimal gland. So, why dry eye is common? Because of the destruction of the goblet cells and the ductules of the lacrimal gland. So, you can see trachoma A is showing the typical white subtarsal follicles. B is showing marked paleness. C is showing stellate conjunctival scarring. D is showing outlines and conjunctival follicles. E is showing Herbert pits, and C is showing the cicatricial entropion. Investigations are rarely used in the affected area, as in most cases the diagnosis can be made based on the clinical feature. Various field technique, for example dipstick enzyme immunoassay, are available, and other investigations are similar to those for adult inclusion conjunctivitis. So, how will you manage the case of the trachoma? The safe strategy for trachoma management is supported by the WHO and other agencies. Encompasses safe is surgery for tracheasis, antibiotics for active disease, facial hygienes, and environmental improvement. So, most common we give is the antibiotics. Antibiotics should be administered to those affected and to all the family members. A single antibiotic course is not always effective in eliminating infection in an individual, and communities may need to receive annual treatment to suppress infection. Very important, you do not have to treat a single individual, you have to treat the communities. So if one member is affected, you have to treat the whole family member. And how will you treat? A single dose of azithromycin 20 milligram per kg up to 1 gram is the treatment of choice. Is erythromycin 500 milligram twice daily for 14 days, or doxycycline 100 milligram twice daily for 10 days. Tetracyclines are relatively contraindicated in pregnancy, breastfeeding, and children under 12. Topical 1% tetracycline ointment is less effective than oral treatment. So basically, you have to treat systemically. Facial cleanliness is a critical preventive measure. Environmental improvements such as access to adequate water and sanitation, as well as control of flies, is important. Surgery is aimed at relieving entropion and trichiasis and maintaining complete lid closure, principally with the bilamellar uh, tarsal rotation. So, why the entropion and trichiasis is formed? Because the conjunctiva is scarred, and when the inside of the conjunctiva is scarred, it causes the entropion of the eyelid. And how will you treat? Basically with the bilamellar tarsal rotation. Systemic tetracycline should not be used in pregnancy and children under 12 years of age because of the risk of tooth staining. So that's it for the conjunctiva part 2. See you in the next lectures. Thank you very much.